Good afternoon, everyone, and welcome to the Independent Sage Friday briefing. As the days go by, the long-term effects of catching COVID are becoming more and more visible to us. The reports from long COVID clinics in the UK point to something that we here at IndySage and others have continued to raise alarm about. That is that COVID poses terrible long-term consequences for many. While reports about long COVID have prompted the spread of further rumours regarding vaccines and masking, the evidence tells us that it is COVID, the short version, that generally leads to the long COVID. We're going to take this point up again briefly later on during this question and answer session. But today we're going to have a dedicated public Q&A session because that's one of our major purposes, to communicate with you guys in the public, and thanks all for all the questions you sent in. But before we take those questions, I'm going to ask Dr Kit Yates to give us a presentation on the latest COVID numbers, trends and statistics. Over to you, Kit.
Thanks, Steve. Just trying to find my unmute button. Hopefully you can all see what I can see now. So yeah, I'm going to go a bit long on the numbers today because there's quite a lot to cover, including the following. So we're going to look at prevalence, in which the picture is sort of unclear because we've lost the ONS COVID infection survey. We're going to look at hospitalizations, which are declining slowly at the moment. We're going to cover deaths briefly, look at vaccinations because the spring booster program is underway, and we're going to look at hospital or NHS England key performance indicators to see how the NHS is faring now that we approach summer after the terrible winter that we had. So firstly, I'm going to look at what I'm now calling cases. So we don't really have great data on the prevalence of COVID in the country at the moment. So what we do still have is test positivity. So this is the number of people who test positive divided by the number of tests that are undertaken. And you can see that it does map along with the data that we've got from ONS, which is showing these two peaks last year, and then or even before that 21, and then these sort of four peaks that we saw, seasonal peaks in last year that we've seen, and then the most recent behavior is suggesting that we are now sort of on a downward tick, but possibly starting to go upwards again. There was a change in testing around here where this grey line is, which is about the 1st of April, I think, where hospitals were advised not to routinely test patients and just to test people if they think it's basically clinically relevant with a PCR test. So there's been a change in testing, and that might have impacted on this positivity. Just to sort of have a look at what's happened, that I've marked that same date, 1st of April, on this graph. This is showing the number of tests that are being undertaken, and you can see that that advice did have an impact on the number of tests that had been steady for a month or two, and then it seems to have dropped, and it's now continuing to decline as people, as hospitals perhaps change their practices. So there are caveats around this data set as well. Just breaking it down at a regional level, you can see that most regions have seen falls. So this is data for the last 4 weeks. So lightest grey is the furthest back, going through to darker grey, and then orange is the most recent week. And you can see that for most regions, we've seen a fall in positivity over the last few weeks, but some regions we've seen a little rise. So although in the last week at least, so although the overall picture is sort of roughly stable, there's been this sort of differing picture across different areas of England. The other thing that we still have is the Zoe symptom tracker, which asks people to report their COVID-like symptoms and then estimates the prevalence from that. So you can see that, again, it tracks roughly what we would expect to have seen from the ONS. And then we've been on this decline for the last month or so. And then we've started to see a little uptick again in the number of daily cases that Zoe app is estimating. So it's a bit of a mixed picture. We've definitely seen a fall. Maybe that we're now starting to see a rise. I suppose now that these peaks and troughs are not so big, though, one of the really important things to emphasize is that it's almost not so important whether things are going up or down in a shallow way as they are at the moment. It's more important that the prevalence levels have remained relatively high. So Zoe is estimating that over 1 million people are still infected across the UK. Whether that's completely accurate or not, it remains to be seen. But certainly, when the last issue of the ONS infection survey, we had about 1 in 40 people infected. So with around 60, 70 million people in the UK, that's about 1.5 million people. So there's reason to believe that this may be roughly accurate, I think. So anyway, the levels of prevalence are high, and that's having some knock-on effects. So that's what we can see when we delve into the murky picture of what I've been calling cases. Hospital COVID is probably slightly more accurate in terms of figuring out, or slightly more reliable, but again, there has been this change in testing. So most recently, we've seen this sort of shallow decline. It's going down about 10% week on week in terms of hospital admissions in England in the latest week, and that seems to be continuing, which is sort of opposite to what we've seen with test positivity, although of course there traditionally is always a lag between people testing positive and then ending up in hospital. Breaking that down into different age groups, you can see the over 65s in red here and the under 65s in grey or silver. And you can see actually that in terms of absolute numbers, it's predominantly 65 and over patients who are entering hospital, and less so for under 65s. And that becomes even more clear when you break it down by rate per 100,000 people. So in the previous graph, let's just jump back to it. This was all people over 65 versus all people under 65. And there are obviously lots more people who are under 65. So the rates of hospital admission per 100,000 people in that age range are significantly higher for the over 65s than for the under 65s. Although the peaks seem to track each other as we get peaks of prevalence passing through the population, the peaks in the under 65 population are significantly smaller than those for the over 65 population. And then just breaking it down again at a regional level, again, it's a slightly mixed picture. So these first few regions that I'm showing you have seen sort of increases in prevalence recently, but on the next slide, the rest of the regions in this other picture, you can see that we're seeing a downturn in those trends over more recent weeks. In terms of looking at the number of occupied beds for England, again, this is mapping the same sort of picture that we've seen with admissions. You can see that admissions are decreasing generally over time for the last month or so. And similarly with mechanical ventilation beds, we're at roughly the lowest level we've been in terms of people on mechanical ventilators for a significant period of time now. So that's a relatively rosy picture in terms of hospitals. Things are getting better, but still we're seeing relatively high levels of people in hospital. Just to compare with flu, you'll hear a lot of people say, well, COVID's no different to flu now. Well, this is the latest flu data, and the dark blue line here is 2022-23, the recent flu season. You see, we had a big peak in flu hospital admissions per 100,000 people this year, especially compared to 2020-21 and 2021-2022, when we had the impact of various restrictions that were keeping flu levels down, certainly in 2020-2021. But you can see that we've had this big spike, and it's much larger than we saw in 2019-20. But when you compare that to COVID, you'll see that there was a period of a couple of weeks when flu overtook COVID in terms of hospital admissions, but actually COVID has high levels of admissions all year round, whereas flu has this single peak in winter. And clearly the combination of those two happening at the same time puts extreme pressure on the NHS over December and November and January of this year and last year. Just having a look at deaths quickly, you can see here that, okay, these are deaths on the death certificate. There is a lag in this data, so we have to be a little bit careful about assuming this downward trend continues into this grey area, because it does take time to register deaths on the death certificate. But actually, you can see that generally the trend is going down following the decreases in hospital admissions that we've been seeing. So that's also relatively good news, I'd argue. And this is just the same picture, but just for England now rather than the whole of the UK. And it almost exactly matches the track for the whole of the UK because the majority of the UK population are English. And then for the other home nations, you can see actually there's sort of small rises perhaps in Scotland in blue here, but falls in Wales and Northern Ireland. So overall in the UK, we're seeing a fall in deaths by death certificate. We've just launched the Spring Booster campaign, or the Spring Booster campaign has just been launched. So looking at vaccination, you can see these are the number of doses of vaccine that have been given. It started off slowly in early April, and that's really picked up and then slowed down again a little bit. Breaking it down, these are now cumulative totals of people who've been given the Spring Booster. You can see that we are increasing still every week, which is good. And we are vaccinating both over 80s and people who are 75 to 79. So it's only available for over 75s, this Spring Booster. And we're also vaccinating immune suppressed people. So I should say that if you're under 75 and immune suppressed, then you can also, or immune compromised, then you can also get one of these boosters. So we are getting these numbers through, although it seems to have slowed down a little bit in the most recent week. And then looking across the different nations, the over 75s who are eligible for this, what proportion of those have been vaccinated? It's a little bit disappointing so far. Only 40% of those in England, better in Scotland, up at 54%, and then lower again in Wales and Northern Ireland. Happy to say that my dad and my stepmom are amongst those 40% in England. So I'd encourage people to go out and get your Spring Booster if you can. Again, just looking at these vaccine recency data, back in autumn, we went through this nice peak where we saw more and more people within 3 months of a vaccine dose. That's the dark green here. But then obviously that program slowed down and finished, and people started to get further and further away from their first vaccine dose. So this green bar filled up. This is people who are 3 to 6 months away, and then the orange has started to take over away. Again, this is people who are more than 6 months away from their latest dose of the vaccine. But you can see, it's good news, right at the right-hand side of this figure, you can see that the numbers of these dark green people who are within 3 months of vaccination is starting to pick up again as we launch this Spring Booster. So that's good news. And again, that's this bar on the right here is just the same as the right-hand bar of the last figure. This is the data for the whole of England, but broken down by age. You can see not much is changing for younger generations because they're not being offered this booster, but for the over 80s, 40% of those are now within 3 months of their last vaccination. Only 8% of 60 to 79s, but of course remember that only a quarter of them, or roughly a quarter of them, the over 75s, are eligible for this vaccine booster. So that's vaccinations, and the last thing that I want to talk about is hospital key performance indicators, which let us know, or NHS key performance indicators, which let us know how the NHS is performing. So firstly, looking at ambulances, good news here is that we did have these extraordinarily high peaks in ambulance waiting times. They have now come down. They're not at their target levels. In fact, they're still much above their target levels and much above where we'd want to see them, but they are coming down at least. This particular graph shows C1 and C1T calls. So these are category 1 calls, the most serious and life-threatening conditions like cardiac arrest, respiratory arrest. And the C1T, the brown curve, is so the red, I should say, is getting a paramedic there on the scene, and the brown is getting the appropriate transport to take that person to hospital if required. So that generally takes longer than the C1 category themselves. But yeah, unfortunately still missing the target, but by not as much as before. Similarly with Cat2, so these include some suspected strokes and heart attacks. We did go up to an absolutely unbelievable over an hour and a half wait on average. This is average waiting times back in December. That has come down dramatically, which is good. and it went up again and came down again a little bit in the last month, but again, we're still above the target, which is actually 18 minutes. I put it as 20 minutes here, it's actually 18 minutes erroneously. So we're still well above that target. But the good news is that category 3 and 4, so the least urgent calls, these are now below their targets of 2 and 3 hours respectively. So these waiting times have come down again, which is good. But remember, they've come down from extremely dangerously high levels, you would argue. And again, looking at the ambulance response times in minutes for these most urgency 1 calls, just looking at the recent trend, again, for different regions, you can see that things have come down generally in the most recent month of data. That's the orange bar, but again, this green bar is indicating what the aim is, the target is, which is 7 minutes, and we're still above that in every region, although only just in London, but in every region we're above that line. And this is the same thing for the category 2 calls. Again, you can see that we're above that line in every region. Moving on to the situation in A&Es, we've got about a quarter of A&E patients waiting longer than 4 hours from arrival to admission. So that's around 460,000 patients, which represents about 25% of the patients in the last month who had to wait longer than 4 hours, which is the target. Again, this is just showing the same data, but it's broken down by year. So you can see earlier on, back in 2019, 2020, we had relatively low proportions of people waiting longer than 4 hours, but then that rose significantly in 2021 and then has gone even higher in 22 and hasn't really come down. It's come down a little bit in the last month, but it's still very high. Similarly, this is the same sort of data, only now people waiting more than 4 hours from the decision to admit them to admission. So there's a period of time when people get to A&E before it's decided that they will be admitted. So this now represents 113,000 patients. And again, it's roughly the same picture. It's around a quarter of those patients waiting longer than 4 hours from the decision to admit to admission. And again, this is the same data, but just broken down by year. And you can see that same pattern, this rise over 2021 and then throughout 2022, and then staying high in 2023. This one, I think, is always one of the most shocking ones. This is people waiting longer than 12 hours from the decision to admit them to admission. I remember when it got above 2% being particularly alarmed by this. It did go up to above 10%, which is astronomical. It's now back down at 5.5%, but despite that, that recent fall, you can see it's still a huge proportion of patients, more than 1 in 20, who are waiting more than 12 hours to be admitted when the decision to admit them has been made. And similarly, these waits are too much for some people, so many people are deciding to leave A&E before their treatment is completed, and that's actually risen in the last month up to about 5%, 4.8%, as you can see, but it's high and it's staying significantly higher than it was pre-pandemic. In terms of people waiting for tests, this is where things are really bad, I think, or continuing to get worse. We've got about 1.7 million people waiting for diagnostic tests. The target is to try and get people a diagnostic test within 6 weeks. And actually, you can see that we've got 400,000 people waiting longer than 6 weeks for a diagnostic test. And similarly, people waiting longer than 13 weeks is 166,000. That's this red line here. And the blue line is the same as the previous slide, people waiting longer than 6 weeks. So people waiting huge amounts of time just to get a test, just to determine what may or may not be wrong with them before they even get to the treatment stage. Okay, so this is waiting for a test. And then in terms of treatment, again, this is another of the sort of headline figures. We've got 7.3 million people waiting for treatment in England. This is 1 in 8 people in England waiting to start treatment, which is amazingly high, really. It's not 1 in 8 patients, it's 1 in 8 people waiting to start treatment in the whole of England. And then when we look at how long people are waiting, the target is that we see 92% of patients within 18 weeks of referral. We're down below 60% at the moment. So huge amounts of people waiting a long time. And then finally, patients waiting longer than a year to start non-emergency consultant treatment is up at 5%. So again, hugely high numbers there. So I'll finish by summarising and saying that cases, it's not easy to determine what's happening. We're still trying to use multiple data sources, but the data is being degraded. We are hoping that the ONS are going to be launching, or they already have launched, in fact, their CRIS survey, COVID and respiratory infection survey, which is going to be asking people how they're feeling rather than testing them. So whether that data will be or it won't be as good as the ONS infection survey, but it might give us an additional data source to find out what's happening. We'll have to wait for that to come out. Hospitalizations, admissions are falling slowly. Deaths are also falling, but relatively high levels compared to the lows that we've seen in previous summers, 21 and 22. And the spring booster program's up and running, which is good news. But the hospital key performance indicators, the NHS key performance indicators, are indicating that the NHS is still in bad shape. So I'll stop there and I'll pass back to you, Steve.
Thanks, Kit. That was a really comprehensive and brilliant summary, even though most of our data sources have seemingly been switched off. Thank you very much. That was brilliant. So now we're going to move on to our main part of today's briefing, which is our public question and answer sessions. And just again to emphasize, we really appreciate you guys all inputting questions and asking us about different subjects, because that's, after all, one of our main purposes for being here. So we're going to start today with someone who's come onto the briefing to ask their question, and that will be Chris Lamb, who's going to ask us a question about something that I think many of us are wondering about at the moment. Over to you, Chris.
Hello, thank you for taking my question. The World Health Organization have declared an end to the global health emergency. Do you think they're right to do that?
There's a challenging question. Okay, who would like to begin on that, perhaps? Professor Susan Mickey?
Yeah, sure, I can. Well, I think this is something that we've all been thinking about. And the WHO kind of abides by quite technical terms. So their definition of what they call a public health emergency of international concern, which is what they declared over. They didn't declare the pandemic over, but the public health emergency of international concern was that it's no longer what they call an extraordinary event requiring a coordinated international response. And they define extraordinary event as serious, sudden, unusual, or unexpected. So, it's no longer sudden, unusual, or unexpected. It has become ordinary rather than extraordinary, unfortunately, but it's still serious. And I think one of the reasons that the WHO, I'm sure a big reason the WHO did this, is because of the pressure of member states, because it has implications for the distribution of resources. And obviously there's a lot of other needs, health needs, other illnesses and diseases that are crying out for resources. But the problem is that the communication of it made it sound like, there's no longer a serious pandemic. And we've heard from what Kit said in this country, there's a serious pandemic. Large numbers of people are dying, are getting long-term disability through long COVID. And this is happening all over the world. Other countries have got more of a wave than we've got here. So I think it reflects the sort of a technical definition. And actually, the Director General was at pains to really say that this doesn't mean that countries should be taking their foot off the pedal in terms of reducing transmission. That this is really still a very serious pandemic. But the trouble is that got lost in a lot of people maybe who want to take the attention away from these problems, really emphasising that the pandemic's over, where it's not over, and that's not what the WHO was saying. So I think one of the problems, it's not really helpful to have these categories of either you're in a public health emergency of international concern or you're not. But I think another issue is, does it still require international coordination? And obviously countries are dealing with this to greater or less extent in different ways. And it's all over the world now. So I think those are some of the reasons behind it. But I think the fallout, the unintended consequences, is quite damaging, and maybe others can pick up on other aspects of it, and also what we should be doing really in terms of communicating to compensate for what was probably a rather unfortunate message that things are less serious than they were, because they're not. Thanks.
Yeah, well said, Susan, well said. Thank you very much. Very, very comprehensive answer. Does anybody else want to add to the sorts of things that Susan has been saying, guys? Aris, do you have an opinion on the pandemic versus the emergency?
I can talk about the pandemic, and I can certainly say that it's not over, right? So we're still in a situation where we have multiple growing epidemics in multiple countries, and an unpredictability of how those waves grow, the timing, the amplitude. So in terms of the scientific definition of a pandemic, it still holds. That is also true of other pandemics that have been with us for far longer, right? So it's not something that should surprise us.
No, absolutely. Christina?
Yeah, so just to emphasize what Aris just said, and a bit what Stephen said. So effectively, the fact that something isn't new anymore doesn't mean it doesn't matter. And I think that the danger is that we hang so much importance on whether WHO has declared something as this new emerging concern or remove that classification, whereas actually the problem we should be focusing on is how big of an issue is this for the health of our population. And nothing has changed from last week to this week in terms of threat of COVID.
No, absolutely right and proper. Len?
Interesting, isn't it? Because I think it depends on who you are and your position. Because if you got COVID and got long COVID, that's not great, and you're recovering. If you're immunocompromised and you know that your risk is still high, then you might be worried. And likewise, if you're a doctor or nurse trying to battle on that waiting list because you've got all this additional work you need to do, and as you see the metrics aren't looking good, they will also want to say it's quite over. And also, if you've got children in school who keep being sent home because they're getting it. So, all these four groups will probably have different viewpoints. And actually, just because one organisation said one thing, you can't deny the truth of what people are experiencing. So it's a difficult one, isn't it?
Yes, absolutely. Absolutely. Well said, Len. Anyone else have anything else to add? Zubaida?
I'm hoping my Wi-Fi is okay. I suppose the other thing I would add is there are still economic consequences to this. The workplace shortages are still being affected. People are falling ill. People are still getting long COVID. And then we've got, as Len mentioned, immunocompromised people who are having to go to work and protect themselves. So we can't ignore the economic consequences. And I think the worst thing that we could do right now is not learn from COVID. And there is a real risk at the moment that we won't learn from COVID. We won't think about the general health of the population. We won't think about how can we protect from the pandemic in the future. And we're not thinking about sick pay. Sick pay was a huge issue during the pandemic. We knew that some 2 million people were not eligible for sick pay. We knew that sick pay was a problem in the sense that it was wholly inadequate. It is still inadequate. And with people falling ill and with the cost of living crisis and not being supported financially, they're having to go to work, they're spreading the virus, and they're not getting the financial support.
That's absolutely right, Zubaida. And maybe to take that a little bit further, there are, of course, countries who have not had extensive vaccination programs and who also don't have, very rich economies such as the United Kingdom does as well. And I also think it's quite interesting how people are very rapid to take this announcement of the emergency being over, whilst kind of ignoring the other aspect of this, as Susan alluded to, which are these 5 pillars of control and maintain surveillance, vaccinations, support, and community action that the WHO have recommended. And it's a real shame that some of that messaging didn't quite get through. Is that enough of an answer for you, Chris? Does that I don't think this is a question of right and wrong, really, is it?
No, very good answers. Thank you. Yes, behind all of that is the lack of data as well. How can you make a decision if you don't have the data?
Sure. Absolutely. Brilliant. Okay, thanks ever so much, Chris, for coming on and for submitting that really pertinent question for us at the moment. So I'm going to move on now to something that we have just touched on as well, and that's start talking about long COVID. And so we have a question from an anonymous contributor around long COVID. And the question is, the WHO said 2 weeks ago that 1 in 10 infections may result in post-COVID conditions. This suggests that hundreds of millions of people will need longer term care going forwards. Why is this not being talked about more? Who would like to deal with that? Do we have any long COVID experts on the panel, Professor Altman?
Yeah, I mean, tough question, isn't it? So I think we don't talk about it because it's too difficult to talk about and too difficult an interface with our politicians. And I don't mean that nationally, I mean that globally, because from the intro that you just gave from the question, conservatively, maybe we're talking about a new long-term healthcare challenge for some 400 million people on the globe. And if nothing else exposes our health inequalities and stress tests our healthcare, that will. So if you wanted to really offer something fit for purpose, you'd say that all of those 400 million across the globe should access clinical care with a doctor in their region who would refer them for specialist care, where there would be long COVID experts who could look at their neurological and respiratory and cardiac and renal and on problems, all under one roof in a dedicated service. We haven't began to get into a place where we dare to grapple with that question, because it's such a big question to grapple with. But I don't, just because it's tough doesn't mean that we should avoid it forever.
No, I completely agree. And actually, Danny, while we're on the subject of long COVID, there's been a sort of series of a groundswell of certain social media commentary this week in light of, there was a big article in the Mirror around long COVID. I myself was on a local news bulletin around long COVID, and there seems to be this movement of people to try and associate long COVID with the actual COVID vaccines. Now, I'm not aware of evidence that supports that, but of course, some people can have adverse vaccine reactions. Rarely, but what do you make of those sorts of accusations?
Sure, let me make a very brief comment. So there was, to my mind, a very good article in the Daily Mirror looking at long COVID clinics, and particularly the service at University College Hospital, headed by Mel Heitman, which to my personal view is almost a kind of gold standard for how that job can be done, because I think she operates a really terrific service. And across the country, there are ups and downs, but the doctors who've had to divert all their attention to long COVID clinics are really heroes in this piece. And I hope and I think that most of the feedback has reflected that. But I've also, as you mentioned, seen quite a lot of feedback of people saying, well, what do they expect? It was caused by the vaccines. It was caused by the masks. It was caused by lockdown. Pick your conspiracy theory. And all I would just say briefly in answer to that, possibly preaching to the converted, that in any evidence-based science, you have a hypothesis. And when you have a groundswell of evidence that doesn't fit the hypothesis, you have to drop it. So in our case, we have a country of 1.7, 1.8 million with long COVID. Many of those long haulers having got their long COVID before there were vaccines, before there were masks, before there were lockdowns. So I think that's the hypothesis disproven quite formally. Not sure what else I need to say to that.
I'm not sure there is much else to say, is there?
Yeah.
But Christina, did you want to add to that?
I just wanted to add a little bit on the WHO numbers, which is that they say post-COVID conditions. That's not all long COVID. It's also things like increased risk heart attack, stroke, potentially diabetes and things like that. And also the risk of long COVID has come down given protection from previous infection and vaccination, which doesn't mean that there are not hundreds of millions of people out there who are suffering, particularly from pre-vaccination era, who just aren't getting better. And we absolutely have to keep researching into how to make it better, not just tracking it, but actually treating it. And also we have to be clear that there is still a risk, but it has gone down a little bit. And also an argument for vaccination, to be honest. There is evidence now that vaccination does reduce your risk.
That's really important. Thank you. Does anyone else want to just chip in on that at all? Sheena, maybe? No?
Am I still muted? Sorry.
Oh,
I can only add a little bit. And I think the key thing that is a lot of studies now have looked at who's more likely to get long COVID, and it's really been linked quite significantly with how severe the disease is. So you're more likely to get long COVID if you've had severe COVID. And actually, the vaccines have been shown to limit the likelihood of you getting severe COVID or dying. And other studies have also then shown that the vaccines, probably because of that, are less likely to give you long COVID. So we have actually seen the converse as well as what Danny kind of phrased so beautifully.
no, absolutely. And just to add finally to this, something that's close to my heart and others I know, we're not vaccinating children anymore going forwards, and children do unfortunately get long COVID. And I think for me that is a real mistake. And I really hope that people will look at this issue, not just in terms of an acute admissions problem, but also in terms of protection from this really quite devastating disease. And we've had people on from long COVID kids, Sarah McFarlane and things on before in the briefing. So thank you, everybody. That was really fantastic. We're going to sort of move to a kind of related subject now, which is moving from long COVID into excess deaths. And we've got a question here from Liz Steele. And she's saying that excess deaths are continuing at high levels in the UK and elsewhere, but I don't see much discussion regarding COVID being a reason. That's to say, illnesses brought on by COVID infections, as Christina's just mentioned, leading to death at some point, not necessarily adjacent to, but after the infections. But then, are these deaths necessarily registered as being involved with COVID or not? So, does anyone have any thoughts on that sort of conundrum? That how do we monitor the sort of latent effects of COVID infections? Kit, do you have something to?
Yeah, I can speak
about numbers.
I can speak a little bit about excess deaths, although that conundrum of how we pair together, long-term impacts of COVID with death certificates is a difficult one, and I don't have an answer to that. But so certainly COVID is contributing to deaths that we didn't have before the pandemic. That's sort of natural that you'd expect, I suppose. But also, I think we're seeing lots of excess deaths as a result of these terrible hospital key performance or NHS key performance indicators that I showed. People who are not getting ambulances quickly enough, people who are waiting longer in A&E. We know that longer waits are associated with worse outcomes for people. In fact, I talked about it a few weeks ago on this briefing that the actuary group, COVID-19 actuary response group, have done some calculations based on those numbers, which were suggesting that in November and December, we were seeing maybe around 500 excess deaths a week just as a result of A&E waiting times. So that's not to speak to ambulance delays or about other waits, delays in the NHS. And actually their estimate was, even based on those waiting times, a conservative estimate. Because those numbers have gone down a bit now, I think they're estimating around 300 excess deaths a week because of that. But certainly there are results of COVID potentially which have impacted the NHS and then are causing non-COVID related excess deaths because there's a backlog in the system. But as the questioner suggests, there are also these potential long-term consequences which are not directly linked to the acute COVID infection, and they may not be being recorded on death certificates.
Yes, Danny, did you have something to add?
Yeah, no, just to build on that, and obviously I'm the worst person to comment on this because I'm not one of the numbers people on the panel, but I can comment and then they can say how clever people could resolve it, because as Kit suggests, this is a cocktail, isn't it, of deaths that have accrued because of the crazy years we've been through, where all those diagnoses were late and missed and treatment was started late, and all of the topsy-turvy world we've been through, and actual COVID-related deaths. So if you look at data sets like the Veteran Affairs data sets in the USA, where you have data sets for millions of people, you see that in a straight comparison between COVID PCR positive and negative, many things like heart attacks, strokes, vascular disease are, incredibly increased in terms of relative risk in the COVID group. So it'll take much cleverer people than me to work out how you disentangle both of those components, but they're both in there.
No, I quite agree. Christina?
So just on that, I just want to make a point that it's going to be really, really difficult to disentangle deaths related to COVID several months later and deaths related to poor performing healthcare systems. Because in the countries that did not control their COVID, they tended to have worse performing healthcare systems, were overwhelmed and burdened for both COVID and non-COVID conditions. And that's another one of the reasons why the countries that managed to control transmission have come out better. And one of the reasons that next time there's a pandemic or new pandemic, we need to kind of think a bit more broadly than just the acute phase.
No, completely, absolutely agree. Anybody else have anything to add on that one? Actually, Liz has a follow-on to that question, guys, which is, I think, something that Danny's actually already addressed, which is how much of these excess deaths do we think are attributable to COVID's impact on our vascular system? But then she also adds to our immune system. So I wondered if anyone had any thoughts about what COVID was doing to our immune systems that might be allowing us to die from other causes, perhaps. I know there are some quite strong views around that sort of thing on social media. I think there's probably a bit of a balance going on there. If anyone has any thoughts to add, Danny?
Sorry, I don't want to hold the discussion. I'll say something very brief and then Sheena should take over. So one thing I think is clear from the data sets, which is across 3 quite strong publications now, that the hazard ratio for autoimmune diseases, several different autoimmune diseases, certainly including things like lupus, vasculitis, and arthritis, are quite considerably increased in, again, COVID possible groups. So things like, 1.5 to 2.5 fold. Then the other thing that you sort of mentioned too about, areas of sort of confusion and lack of consensus, above and beyond that, which clearly does reflect some kind of immune perturbance. Has COVID done strange and weird and unpredicted things to our immune systems? So many different papers and publications and rival claims out there that I wouldn't dare kind of pronounce on this, for a while longer until we've got another 500 publications and know what on earth is going on.
I think that's a very fair standpoint to take, Danny. Sheena, did you have something to add?
I think just to add to what Danny said is that particularly from severe COVID, we are seeing a lot more evidence now across lots of publications of this sort of increased risk of autoimmunity, but there's also been a number of papers showing increased risk of diabetes, and diabetes in itself is associated with increased risk of other conditions. So there clearly is something going on with the immune response, and this seems to be more likely to happen if you've had a severe infection. And we do see sort of different things happening in long COVID. There definitely seems to be more and more evidence about discrete immune signatures emerging. And a recent paper was addressing this multi-inflammatory syndrome condition that some children get. And again, they were seeing sort of these altered signatures of immune cells, so this bias away from sort of a good antibody response towards a more kind of inflammatory cytokine producing response that's going to potentially be more damaging. So there is some evidence. For the majority of cases, though, as Danny says, there's a few studies that have come out and tried to, and I think some people are sort of making claims that they say that all of us now have an immune deficit. We're really susceptible to infection. I don't think the papers are really saying that at the moment. I'm not really seeing the evidence for that. We're seeing some changes in some markers, but these could also be changes in the way that T cells work normally when they've been activated in a response, in an immune response. So it isn't evidence necessarily that they have an impaired function. And I think we'd have to see lots of other kind of epidemiological evidence, for example, of a lot of recurrence of, say, infections that we call latent infections that kind of hide in your body and wake up when you're really run down, And I haven't seen a lot of data about that. I think this is all hinging on the fact that we had this sort of triple tsunami in the winter of RSV, influenza, and COVID. And I don't think that's quite compelling enough to really be making that statement. But I will obviously, if the data starts saying otherwise, I will definitely hold back my views at the moment.
Fair enough. I would add actually that there is a short-term element about innate immunity, which the virus is getting, it evolves and gets better at suppressing innate immunity as things go by. And Omicron has clearly done that. There's some lovely work by Lucy Thorne and Greg Towers that's showing that at the moment. So there's that, maybe that short-term suppression that might predispose to other things happening, but we don't. I agree. I think that the jury's definitely out on the longer term adaptive responses. Okay, so I shall move swiftly on to a question from Andrew Broadbent, who I think this question's probably actually been answered really by Kit's data briefing. But Andrew asks, can IndySage comment on the usefulness of the Zoe COVID tracker, which seems to still show infections over 1 million in the UK? I think Kit or Christina, did you want to add to anything that you said in the briefing? Or are we still okay relying on Zoe? Are there some problems with uptake?
I mean, we're always a bit cautious about Zoe because of the methodology. We know that they have in the past had to sort of refactor their data to make it look more like the ONS data, which we know is or was the gold standard. So Zoe, I always take with a pinch of salt and try to look for multiple sources. But where it has been pretty good is it picking up peaks and troughs and turns in the data when we start to see something new taking off. As I said though earlier on, it's probably less important to know when things are rising or falling because they're not doing that so steeply at the moment. Potentially they may do in the future if there's another incredibly transmissible or immune escaping invariant. It'll be important to know that, but really actually it's sort of the absolute numbers that are the important thing to be keeping an eye on, and they're steadying out at relatively high levels, I think. So Zoe, yes, useful part of the picture, but not everything.
Great, thanks Kit. Yeah, I think that's right. And of course, Christina.
Yeah, so just to say that ONS is restarting its survey side of its infection survey. So they're not doing tests, but they are going to be asking a random set of people about symptoms. So in that sense, it's kind of going to be a bit like Zoe, but with a randomized population responding. So I think that will also be really interesting.
Will those two feed into one another and be able to self-correct in the way that the other test did, or is that remains to be seen?
Well, I don't think there's any kind of formal link. Now, whether Zoe starts recalibrating again, I don't know, but it'll give us 2 points of reference. And I think the first ONS data will come out in June or July.
Oh, that's good to hear. That's good to hear. Right, brilliant. Thank you, everyone. So moving on to a different sort of subject here, a question from Jacqueline Connell. And Jacqueline asks, I've read that the Arcturus so-called variant, which is XBB 1.16, can only be identified by PCR. Is this true? Does anyone know the answer to that? I suspect it's not true, based on the fact that there aren't particularly that many mutations in the N protein, which is what is detected on lateral flow tests. Aris, do you know of any sequence changes that would disrupt PCR primers? I'm not aware of any.
I haven't seen something to suggest that that's the case.
Okay, so I think the very short answer to your question, Jacqueline, is no. So I'll move on to a different area here, which is much more of a healthcare concern, which I think many of us are becoming increasingly concerned about at the moment. And this is from COVID Action Scotland. The Scottish government states that from the 16th of May, staff working in care homes should no longer be allowed, not encouraged or advised, should not be allowed to wear a mask, even if they wanted to. Also, masks are no longer advised anywhere in healthcare unless the healthcare worker gets a personal risk assessment saying they need one. Do you think that this could be open to challenge? You'd hope so. Haven't seen such draconian no masks allowed statements like that for care homes anywhere else so far. Does anyone have any knowledge of this or an opinion? I can probably guess what the opinions might be. Christina?
I mean, that's just ridiculous, isn't it? I mean, at the moment when staff are encouraged not to test and they're encouraged to go to work if they feel well enough to work, even if they have symptoms. The idea that you will actually say you're literally not allowed to wear a mask when you're treating the most vulnerable people is just, it's just ridiculous. In terms of the broader question, I don't know what other care homes are doing. I can say that my dad is in a nursing home and none of the staff wear masks, but I'm the only one who ever wears masks when I'm in that home. So.
That is good to hear. Any of our other healthcare colleagues, Helen, Len? Helen?
It does seem quite ridiculous. We are, in my surgery, a bit of an outlier in that we're still asking our patients to wear masks in the waiting room on the grounds that other patients there may be clinically vulnerable. And we leave it to each clinician within their own consulting room about whether they wear a mask and ask their patient to wear a mask. But certainly, if a patient comes to me with respiratory symptoms, I would rather they wore a mask. And certainly if I had any of those symptoms, I would be wearing a mask all the time, and I keep my window open. And if you're in a care home, if you're a care home worker who's got respiratory symptoms, why would you not wear a mask? It seems ludicrous. I can't get my head round a mindset that says we shouldn't be trying to halt the spread of respiratory infections. COVID aside, we now have a much better understanding of how masks stop all sorts of other infections. We have this tool. It's simple. It makes no sense. And a lot of the people who are in care homes are vulnerable. We saw those graphs at the beginning, which did still show 70 deaths a week. That's many thousands of deaths a year, mostly in older people with COVID on the death certificate. It makes me really quite angry to think people may be deliberately saying you can't wear a mask. It may get more difficult to insist that everybody does, but to say you can't makes no sense.
I completely agree. Len, and then I think Susan would like to say something as well.
I think I'll just say that I think it's very reasonable people don't want to get COVID. I completely, and that's really important because there's all kind of side effects you can get. And if you end up in a hospital, it's really bad. I think the one thing that you can choose to do is get your boosted, make sure your vaccination up to date, and wear a mask. I think the tricky thing is that it's really difficult because you can control your actions, but then trying to get other people to make the right choice is just incredibly hard. And there's a temptation to just get so angry about this. And I think ultimately one of the things you've got to do is talk to that person. And I know it shouldn't necessarily be in you to have that chat, how the system will respond. But if you do feel uncomfortable, tell them why. Because at the end of the day, it's just people to people, and they make decisions in the department. A tricky thing is I think we moved beyond the place where government want to take a position this, and they will say everyone wear masks at all times. And that kicked up. I think now we've come to a situation where you've got to have local decision making. And we just hope that people continue to be sensible now, because at the end of the day, we have to respect everyone else, and they've got different risk factors, and some of them are hidden. I think ultimately we've got to try and communicate more on the benefits of this and also why you want to do it. But I can see it's a distressing situation for so many people at the moment.
I completely agree. Susan?
I haven't seen the text of this guidance. I actually find it very hard to believe that is the exact wording. So I think it would be worth us checking on that.
Yeah.
But I think another dimension here is that hospitals and care homes and all healthcare facilities are not only places where ill and vulnerable people are looked after, they're also workplaces. And there's legislation covering workplaces about health and safety. This is how the public smoking ban got introduced. Through workplace safety of those working in pubs and bars and restaurants, etc. So I think, there may easily be issues raised by staff if they feel they're having their health put at risk knowingly by other staff who are being asked by employers to come in when they have symptoms and are not wearing PPE. So I would have thought that there could be some route to trying to improve the situation through that. But I'm sure others who know a lot more about this than me have thought of all of this.
Yeah, absolutely. And there are several questions around masks coming in this week, some from Amelia, Alice, again, around specifically, immunocompromised patients having to go into hospital, I myself have been contacted by cancer patients going into hospital, and they're concerned about this, whether or not it's happening on the ward. They still have to walk through communal areas, go in lifts and what have you. I think it's really disturbing that there's no central guidance on this sort of thing. I think there are so many related questions here that I might just miss the rest of the masks and go on to boosters, vaccine boosters. And this is a question from AJ Kirkwood. And he is asking, for his mother, what is in the current 75 plus booster? Is it the same bivalent one that we had in November? And what benefit will it bring? Or if refused, what would his mother lose to an 86-year-old who doesn't go out and doesn't have carers coming in? So basically asking, is it worth getting this booster and what's in it? Helen?
It very much depends which booster you're going to get. So we had, at the beginning of this spring campaign, we had some of the new boosters, the Sanofi one, which was it's a vaccine made a little bit like the flu vaccine, so a protein-based vaccine rather than mRNA vaccine, which the Pfizer ones were. We only had it for one clinic and then they ran out of it. So now we're back to the same one that we were using just a little while ago, which is the bivalent booster vaccine. It will depend hugely which part of the country you're in, which vaccine you actually get, and it may be difficult to know even in advance of the clinic which one you're going to get, because it's complete patchwork at the moment, depending on where you are, which vaccine you have. I would probably say if you're offered one, go with whatever you're offered, because I think any vaccine boost is better than none. Sorry, that's best I can do at the moment.
No, absolutely right. And do we know if it's still the BA1 bivalent, guys, or is it the BA5? Because I know it was approved, but I don't know if we've actually bought any yet. Does anyone know about that? BA5 obviously being a more recent strain of Omicron, BA1 being the very first one. So BA5 probably a bit more relevant in terms of giving you protective antibody immunity. Okay.
I don't think we ever got that latest one.
I think you're right, unlike the rest of the world. And then, of course, there's another vaccine, which is a kill virus particle vaccine, which is it's beta variant, wasn't it, if I remember, something like that. Anyway, so a mishmash of vaccines, hard to tell, but I think it's all agreeable that getting your vaccine is certainly better than not getting your vaccine, because you just cannot control everything, and it will improve your immune system, especially if you're older. So a related question here from Orla Mulholland is about the eligibility for vaccines. Do we think that it's right that the eligibility is set at over 75s for this fourth dose? And if you're therefore in increased risk, but under that age, and you don't qualify in some of these very pigeonholed medical conditions, is it right that you're not able to get a COVID vaccine booster this spring, but then you may even be able to get it in the autumn? So what's the difference there in terms of timing? Does anyone have any thoughts on that? I mean, one thing that strikes me is that pregnant women can have one in the autumn, but not in spring, for example, which I always find very strange. Kit, do you have something to say?
I suppose, yeah, there is evidence that people under 75 are, of course, at increased risk of adverse outcomes from COVID. So we could be protecting more people by offering it to younger age cohorts, going down maybe even to 60. With flu, we do it for free for over 50s, I think. Most recently, that's the policy that's been implemented. I imagine that the reason why you can get one in autumn and not in spring is to do with the idea of seasonality and the fact that there's going to be increased prevalence in winter. But of course, you know, as we've seen with COVID, it's not yet, if it ever will be, it's not really a seasonal virus. I mean, yes, there is increased transmission in winter when people are meeting up with each other inside more, but actually we saw a wave of COVID every season last year. So I think if that is the reason, then I don't really buy that as being a particularly good reason. And I don't know the full reasons why some people are being offered it in spring and not in autumn and not in spring. So
no, Yeah, I completely agree. It's not seasonal, it's actually perennial, isn't it? Yes, so I think just time for one more very quick question, if I may, just before we finish. And this is a very straightforward question, I think, from Arushi Thapa saying, could you tell us about the link between COVID and bronchitis? Does COVID cause bronchitis? Clinical people?
Interesting question. Bronchitis is a funny word anyway, because it doesn't really have a proper, it's a word that is used often in common speech, but it doesn't map one-to-one on anything people that medics talk about. So it's quite difficult to say. So I guess it's a tendency to get lung infections and possibly upper airway infections a bit more than a pneumonia, which is a lower airway infection. But it's not something that we use very much. I guess quite a lot of people who we would have thought of having bronchitis would be probably people who now would be called to having chronic obstructive airway disease, which is often what happens to smokers. I don't think that COVID itself has led to that illness, but I think some people with long COVID have persistent cough, persistent lung illness. We probably wouldn't call it long bronchitis, but that's because in medicine, we probably wouldn't call very much at all bronchitis. I don't know whether that's helpful at all.
No, that makes sense. Thanks a lot, Helen. That's really important. The bronchi being slightly larger parts of the lung airway. COVID in the old-fashioned ways used to cause inflammation much further down. So a pneumonitis or a bronchiolitis, I guess, is the sort of technical discrimination that we're making. Okay, so thanks ever so much, Helen. That was really useful. And I think we should wrap it up there because we've gone just slightly over time. That's all we have time for today, guys. Thank you so much for sharing your stories and your concerns with us. We're grateful for you putting your trust in us to answer these questions to the best of our abilities. I'd like to thank everyone on our panel for your expert insights and very clear and vocal explanations of these answers. And we're going to be back in 2 weeks' time, same place, new subject. So till then, keep safe and we'll see you next time. Take care, everyone.
Bye.